Module 1, Perioperative Nursing, Intraoperative Phase. We are going to begin with different surgical settings. So we have inpatient surgical settings and we have outpatient surgical settings. So by now you should be familiar with the terms ambulatory and outpatient. They essentially mean the same thing. So an ambulatory center means that you can ambulate in and out. You can walk in and you can walk out. Same with outpatient. Outpatient just means you are not an inpatient. Inpatient refers to being admitted to a hospital and you're actually staying there, you're sleeping there, okay? Ambulatory slash outpatient, you're not sleeping there, you come in and you come out. So what is the difference? So in an inpatient surgical setting, you are going to be required to be admitted to the hospital when you are done with your surgery. So maybe you walked in, you had your surgery, but you're not going to be discharged. You're going to go and sleep on a floor in the hospital. When you are admitted as an inpatient, typically they are very long surgeries and very invasive surgeries. So if you're having brain surgery, for example, that will not be in an outpatient setting. You are likely to be admitted to the hospital for observation. You're going to sleep at the hospital. Inpatient surgical settings usually will require that the patient has to be monitored more closely for more than 24 hours after the surgery has been done. Okay, so if you're going to be admitted to the hospital after an inpatient surgical setting, you are going to probably be having a long surgery, an invasive surgery, a very high risk surgery where we need to monitor you closely for more than 24 hours. In the ambulatory or outpatient surgery setting, you don't have to be admitted to the hospital, okay? The surgery center maybe just be a freestanding building with the closest hospital 5 miles away, or it can actually be in the hospital. So technically you can have an outpatient surgery at a center located in the hospital. We also call it same-day surgery sometimes, and typically these are less invasive. So you're not going to have, again, a brain surgery in an outpatient setting. This requires a shorter time in the operating room and less than 24 hours of monitored recovery time. So for our exam purposes, do you need to know all of these? Absolutely not, but you just need to know the concept. If you're going to a surgical center, then you're expected to walk in and walk out. You're not going to have a really long invasive surgery versus if you're having it in the hospital, we want that emergency equipment there. So you probably are having a long surgery, more invasive surgery. Surgical categories. We have elective, we have urgent, and we have emergency surgery. So elective surgery is just that you're electing to have it. It's not urgent, it's not an emergency. This can include maybe you have an issue, or maybe it's a cosmetic surgery. You want to have a tummy tuck, an abdominoplasty. So you can schedule that way in advance. You can schedule that 6 months from now. So it is an elective surgery. Urgent surgery means it needs to happen, but it doesn't need to happen today. So maybe you hurt your knee, you tore your meniscus, and you have a couple days. You don't have to have the surgery today, but maybe you scheduled it for the end of the week. So that is an urgent surgery that needs to happen, but it doesn't need to happen in that moment. Emergency surgery is traumatic. You were in a car accident, you severed something, and you have to have surgery now. There is no waiting. So we're going to get into it. We're going to talk about the priorities for an intraoperative patient. Intraoperative means the patient is in the operating room. These are all the points that we're going to talk about. The roles and responsibilities of the OR team members, our priority assessments. We're going to get into a little bit of the anesthesia component, management of our airway, risks and complications, and then ways that the RN can support the patient and their family. So let's talk about our team members in the operating room. We have sterile team members and we have non-sterile team members. So let's talk about these sterile team members, very important. So these people are going to work within the sterile field and they are all responsible for maintaining asepsis throughout the surgical procedure. So what is asepsis? So asepsis means that there are no microorganisms. Well, at least we're trying really hard not to have any microorganisms. So if you wash your hands underwater, with soap and water, you are not sterile. You're pretty clean, but you're not sterile. Sterility means that there are almost zero contaminants 0 microorganisms to the best of our ability in that area. So this is going to include the surgeon, surgical assistants, the scrub nurse, or surgical tech / OR technician, and we will define each of those roles. Now I want you to look at this picture here. So we have red and green. So red is indicating of non-sterile surfaces. Okay, so you can see the person on the left is handing something to the person on the right. The person on the left is not sterile. Okay, they're clean, but they're not sterile. Now the person on the right, will say that this is the surgeon. You can see the front half of that person, front top half, is sterile. And the person laying down having the surgery is also sterile on top. But I want you to notice that under the elbows, or let me scratch that, below the waist is non-sterile. Okay, so these people need to keep their hands above their waist at all times. If their hands drop below their waist, they are considered to have contaminated the sterile field. Okay, so very important. Next, we have the surgeon. So the surgeon is the leader of the surgical team. They're the ones who are going to be slicing and dicing. They're the ones who actually do the surgery. And they may have another provider assisting. It can be an intern, it can be a resident, or it can just be that one surgeon. Next are surgical assistants. Again, these are sterile team members. So these are practitioners. Now we're using the word practitioners because it can be a physician's assistant, it can be a nurse practitioner, it can be an RN first assistant, it can be a surgical first assistant. Okay, so a practitioner with specialized training. So you, as the RN, let's talk about the RN, you can be an NP or you can be an RNFA. Lots of money to be made there, and it's a very good career for you to be in if you're interested in OR nursing. Now this will what they can do in the operating room will differ a little bit depending on the state you live in, because each state has its own regulations on what they can and cannot do. But generally speaking, these surgical assistants are allowed to help surgeons. They may be able to make incisions, they can place clamps during the surgery, they can close surgical sites. So it really just depends on the state that you live in on how much they can actually do legally. Scrub nurse, surgical tech, and OR tech. Now in this picture you can see with the yellow arrow the person that I'm talking about. Again, they are sterile, so they are in the sterile field, and they have lots of roles before, during, and after surgery, and it really has to do with the surgery itself. So before surgery, they can help set up instruments and equipment, sterile drapes, sterile solutions, and they help the surgical team don their outfit, okay? And we're not going to go too much into that. During surgery, they can pass instruments or sponges. They're going to help count the sponges and needles or whatever other equipment is used, and they can help prepare specimens that are taken during the surgery. And after surgery, they're going to help disassemble all of that sterile field and help to get everything ready to be cleaned and sterilized for the next procedure. Okay, so those were the sterile team members. Now we're going to talk about the non-sterile team members. So while the surgery is happening, there are lots of people in the room, and those people that are not part of the surgery itself are not sterile. So you can see in this picture who is sterile and who is not. Everybody in the blue is sterile, but the people in the aqua scrubs are not sterile. This is going to include the anesthesia provider, circulating RN, any UAPs, and all of management like OR director, coordinator / manager. So the anesthesiologist, now we say anesthesia provider because it doesn't necessarily have to be a physician. It can be a CRNA, a certified registered nurse anesthetist. Again, another great career path for you, those interested in the OR. Unlicensed assisted personnel, UAP, this could be a CNA, for example. These staff work under the peri-op RN. So if you're working there, they work under you and are directed by you. And typically these people help transport patients to the OR and help the patient, get situated on the operating table. And then of course we have our management. I'll let you read through that. They do staffing, budgeting, all that other kind of stuff. So we're going to talk a little bit about the circulating registered nurse. So it's important for you to remember that the circulating RN is non-sterile. And the patient belongs to the circulating RN. So for example, when you're working on Med-Surg and you're given your assignment of your 5 patients, those are your patients, you're accountable for them. Well, the circulating RN in the OR is accountable for that patient. That is your patient. And you'll be the go-to person for that patient. So when the pre-op nurse transfers the patient to the OR, it's the circulating nurse that is receiving handoff report. The circulating RN is talking to the patient saying, hi, I'm going to be your nurse today, that kind of thing. You're going to do your own assessment. You can read through this slide. This gives you a nice detailed overview of what you're responsible for. So a couple of things is you will be the one calling the family during the surgery to provide updates. Again, you're not sterile, and sometimes you actually have more than one patient that you're the circulating nurse for. So you can be going into multiple operating rooms at once. I'm not going to go through all this information, but just the points to remember is that this patient belongs to you if you're the circulating RN, and you are responsible for updating the family. Okay, so priority assessments and procedures intraoperatively. So we already know about the pre-op assessment. We're going to talk about the surgical pause, the hand scrub, the surgical attire, and the surgical count. So pre-op assessment should have been done in pre-op, but depending on the facility, maybe you're in a rural hospital and maybe the circulating nurse and the pre-op nurse overlap. Who knows? But we already know what we need to make sure is done prior to the surgery. So we want to make sure that they know what they're going to have done, that the consent is complete. We make sure the patient isn't too anxious, and we want to get that relevant assessment data from the patient because we might need to let the surgeon know. Next is our surgical pause timeout. Now you remember in the pre-op area, we did a mini one. Now this is going to be the full one that happens inside the operating room. Now the way that this is executed will vary depending on facility and the type of surgery, but typically hospitals that have a lot of surgeries will have a standardized procedure like pictured here. There can be a board on the wall where everybody can see, and then they go through it out loud so everybody can hear. This is typically led by the surgeon. Okay, so the surgeons should say, okay, time out, let's do our surgical pause, correct patient, they'll state the name, what kind of procedure, the name of the surgeon, is the patient in the correct position, do we have all the equipment necessary for this type of procedure, do we have all of the imaging studies ready, was that medication given prior if there was an order for it, and they also conduct a fire risk assessment, which we will talk a little bit about next. So this is something that is required to do. This is not optional. This is something that is evidence-based. Research has been shown that if this is done correctly, then there is very little chance that there will be an error made during surgery. The wrong limb isn't going to be cut off. It's going to be the correct patient. Everything is going to match. So this is a requirement. So what is a fire risk? So in the operating room, there can be fires. There are cautery tools that heat up during surgery for some surgeries. So it's really important that this check is done. Also, oxygen is combustible. So we want to make sure that all of those safety checks are done, and I will let you read through this on your own. Surgical scrub. You did this in skills lab. So a true surgical scrub is just like that ATI video. It's at least 3 to 5 minutes long and sometimes longer. Typically in the OR, the first surgical scrub of the day is 10 minutes long for all staff. So again, we're not going to get too into it. This module, the intent is not to train you to be an OR nurse. It is just giving you the basics. So just know there is a surgical scrub that needs to be done because we are trying to prevent infection. We want a good outcome for our patients. Jewelry is removed, nails are clean and short. If you plan to work in the OR, you're not going to have acrylic nails, you're not going to have long nails. This is just a little picture for you. So I want you to remember this. When we say we're using aseptic technique, oftentimes you think we're using clean technique. Like when we insert an IV, we're using aseptic technique. We're not using sterile technique. But for our purposes, when you read the word asepsis, okay, and I'm talking about the exam, if you see the word asepsis, I want you to think sterile. Okay, this picture uses medical asepsis and surgical asepsis, but that's not the verbiage I want you to remember. I want you to know asepsis, we are going to consider sterile. Okay, so if we're trying to maintain asepsis, we are trying to maintain sterility because we're talking about the operating room. All right, moving on to surgical attire. So anyone who is a sterile team member has to wear sterile surgical attire. And you can see here, I believe there's a video on ATI that also walks you through how that's done. Now, if you are not sterile, there are OR requirements also. Usually you have to wear scrubs that you don't wear from home. You get them from the hospital, you change into them, you wear a bonnet. Now, you wore shoe covers in Skills Lab, and that was actually just an activity. Shoe covers aren't readily worn in the OR anymore. I mean, some ORs may, but usually that's not a requirement. You just wear your regular shoes. So anyway, surgical attire must be worn in the surgical area. So if you have an opportunity at clinical to go into the OR, you'll notice that there are red lines on the floor where there are signs posted that say, if you're not in surgical attire, you cannot pass the red line. And that doesn't mean that you're sterile, but you do need to be in the appropriate scrubs and bonnet and sometimes surgical mask or whatever that facility requires. Once you go into the OR where it's a sterile environment, then those sterile surgical team members will have that extra layer of sterile attire. Anesthesia. Okay, so now we're talking about putting patients to sleep. So the goals of anesthesia could be amnesia, so they don't remember, analgesia, so they don't feel pain, depression of reflexes, so they don't move, muscle relaxation, again, so they don't move, and manipulation of our physiological systems and functions, and that is per your textbook. So there are several types of anesthesia. We have general, regional, local, monitored anesthesia care, which we refer to as MAC. First off is general anesthesia. So this is a reversible unconscious state. So the patient is unconscious on purpose, and this is what we refer to as being put to sleep. Depending on the surgeon, they can use different modalities. So they can give you medication that you inhale in combination with an IV medication. Just remember that if you are receiving a muscle relaxant, you will need to have airway support. So if we put our muscles to sleep, then we can't keep our airway open on our own. So we will need to be intubated and on a ventilator to make sure that we are breathing. So this is just a little bit more information. You can see the medication names. So medications that we inhale are listed there. Some IV medications that are used are listed there. Do you need to know these names? No, you don't need to know each name, but just know that for general anesthesia, there can be a use of one of these or a combination of these to achieve whatever effect the surgeon needs for that particular surgery. And again, any type of muscle relaxant, that patient needs to be intubated. Some complications that can occur from general anesthesia. Now, this is where you come in because this is what we're monitoring for. Hypoxia. So you should definitely be aware of those early signs of hypoxia and the late signs of hypoxia. So early signs of hypoxia, if you remember, could be, for example, altered level of consciousness, restlessness, increased respiration rate. Later, things start to slow down, so you might be bradycardic, you might have some cyanosis. Hopefully, you catch hypoxia early in the OR. Respiratory and cardiovascular dysfunction, and that's just kind of generalized. They can develop an arrhythmia, they can go into cardiac arrest, they can develop hypotension or hypertension, electrolyte imbalances. They can have some muscle paralysis even after that muscle relaxant has been stopped. Neural problems, they can develop dementia, they can have a hard time waking up. They can also develop something called malignant hyperthermia, and that is what we're going to focus on. So malignant hyperthermia, now this is something that is triggered by usually a volatile gas such as succinylcholine. Okay, so not all medications are at high risk for triggering this condition, but especially succinylcholine. Okay, so this is something that is triggered, and what happens is it causes muscular contraction. So sustained muscular contraction. So pretty much all your muscles from head to toe start contracting and you get very, very rigid. And it causes problems. That is not good. And it puts the body into a state of hypermetabolism. So hypermetabolism is going to cause everything to speed up. Your heart's going to speed up, you're going to sweat, your temperature is going to go up, you can have seizures, and ultimately you can go into acidosis, you can start retaining carbon dioxide. All of these things happen. Now, what I want you to focus on is what is the pathophys? So the pathophys is going to be a state of hypermetabolism and muscular contraction. This can happen immediately once that medication is given to the patient, or it can be delayed. It can be during the surgery or sometimes even post-operatively. So this is a medical emergency because if left untreated, the patient will die. Okay, so malignant hyperthermia is fatal. So it's important that you know what the treatment is. What are the interventions we need to do for a patient that is developing this? And one thing to note is that the first sign or an early sign of malignant hyperthermia is tachycardia. So maybe the patient is in the middle of the surgery and then all of a sudden their heart rate just goes up. All the other vital signs are the same. Nothing really changed during the surgery, but all of a sudden their heart rate is tachy and they don't know why. The first thing that you should suspect is malignant hyperthermia. So what needs to happen is, just like any type of reaction to a medication, you need to stop that medication. So we already know that it is likely going to be a volatile gas. So if the patient is on succinylcholine, they need to stop it and switch it out with something else to keep that patient sedated. Okay, so stop the medication. And then we can give dantrolene. So dantrolene is going to help to relax those muscles that are super rigid. Okay, and also because a patient is in this hypermetabolic state, they're going to be really hot. So we need to cool them down. And we're going to do that by infusing cold normal saline, because we're not just talking about a slightly elevated temperature. These patients are going to be like 103, 104. They're getting really hot. So we can infuse cold NS. We want to remove those drapes because during surgery, we typically put drapes over the body and just keep the area of the surgical site exposed. But we want to take everything off. We can use cold packs. And if we have to, we even can do a nasogastric lavage. So that's where a NG tube is inserted and we infuse cold solution and take it out, infuse cold solution and take it out. So it's important that you know how a patient can develop this malignant hyperthermia and what we do for it. Next, we have regional anesthesia. So this is where there is a local anesthetic used on a certain part of the body. The three types that I'm going to mention are spinal, epidural, and nerve block. So the spinal and the epidural, the only difference is which space the needle enters into the spine. So what I want you to remember about the spinal anesthesia is that it has potential to have a cerebral spinal fluid leak after the puncture. So with these patients, we want to make sure we keep them flat after it's administered so they don't get a headache. So because they're entering that interthecal space with the spinal anesthesia, when you have a CSF leak, even if it's just a few drops that leak out of that puncture site, it can kind of offset your brain fluid, your brain CSF, and that will manifest as a headache. So if you have a patient that had a spinal anesthetic and they're complaining of a headache, you'll want to lower their head of the bed and have them lay flat, and that should relieve the headache. So you can see in the picture, spinals are usually done for the lumbar spine and down. Epidural, typically if you need it a little higher. And then a peripheral nerve block is where they inject the anesthetic for just a small part of the body. So the patient is only anesthetized for that certain area that they're working on. Next is a local anesthetic. So this one is one of the ones with the least amount of side effects. So it doesn't really go systemic. It just stays in that local area. You recover pretty fast. You are discharged. You don't really have to have a long drawn recovery, and it shouldn't affect you neurologically. So there are some adverse reactions if you give too much, or maybe you're just hypersensitive. Just like any medication that you're giving, you could develop some type of allergy like itching or a rash or even anaphylaxis. So even though typically that doesn't happen, we still always have to be on our toes and look out for these things. And pictured here is one example of Novocaine during a dental procedure. And finally, we have our monitored anesthesia care, or MAC for short. So this one, the patient is not unconscious. They're kind of like in a loopy state, they're still arousable, they can still follow commands potentially, but they're not unconscious. So what I want you to remember about this one is that the patient is still awake. So this is, for example, MAC is used with a colonoscopy. So during a colonoscopy, the provider is still able to talk to the patient if they have to. The patient can be aroused, they can be asked a question, but typically they don't remember much. And there's a sign that's placed on the door that says patient awake, because we don't want staff talking about things they shouldn't be talking about because the patient is awake. And sometimes they forget and they're having conversations. So that's what that means when it says patient awake. So the objectives of using MAC is to maintain consciousness. For whatever reason, they do want you to be awake. It elevates the pain threshold. So something that may have been very painful for that patient, when they're under this type of anesthesia, they're more comfortable and relaxed, and that pain doesn't really affect them like it would if they didn't have this. Enhanced cooperation, they do have some degree of amnesia. So like that example I gave you with the colonoscopy, some people don't remember anything. They actually go to sleep, where some patients do have some memory. Minimal variation in vital signs, so the patient is kept more stable and they recover much faster because they're not fully asleep. Now we'll talk about airway management. So patients that require intubation, we need to remember a few things. When you intubate a patient, that means that you are inserting a endotracheal tube, an ET tube, down into the mouth, into the trachea to help us breathe. It will be connected to a ventilator. So some complications that can happen: laryngospasm. So our larynx is located in our neck area, and it is comprised of several different structures, but what we're talking about is our vocal cords. So our vocal cords allow air to pass through as we breathe, and that's what allows us to make sound. So those vocal cords, we have two of them that kind of open and shut. They can spasm, and they spasm for lots of different reasons. They can spasm if we touch them, if we manipulate them. It can be that ET tube just rushing past them. It doesn't matter. Sometimes if you have like inflammation there, that can cause a laryngospasm. What's very scary and dangerous about a laryngospasm is that if your vocal cords, especially if both of them begin to spasm, they will shut closed, and then we can't breathe and we can't pass an ET tube through there. So it's really important that you always have emergency equipment at the bedside. Okay, during the surgery and especially post-operatively, because that can happen during recovery. Bronchial intubation, that is where they stick that ET tube in and it actually goes too far down into one of the bronchioles. So when they connect the ventilator, only one side of the lung is being inflated. So that would be bad. Tracheoesophageal perforation. So again, they're putting in that ET tube and then it perforates or punches through the esophagus or the trachea. Again, all bad. And then of course, aspiration. We're always going to keep that aspiration complication in our pocket because it follows us throughout nursing school. So we want to, again, make sure that we always have emergency equipment, including an ambu bag, suction equipment, extra airways, and ET tubes at the bedside. And this is during the surgery and also post-operatively during recovery. Now let's talk about suctioning. Your role as the RN during the intubation procedure is to be on standby so you can suction the patient's mouth to make sure that none of those secretions will go into the lungs during or right after intubation. Moving on, we are going to look at this slide with common intraoperative positions. So again, this is just going to depend on the surgery and what area they need to get to. So we have supine, prone, lateral, and lithotomy. Here are some more. And I included a third one just to show you that we have to get creative to access certain areas of the body. So now that you know those areas, those different positions, we need to make sure that we are keeping our patients safe. So we want to hopefully prevent pressure on nerves, skin over bony prominences, those sensitive areas like earlobes and eyes. We want to make sure that vessels aren't being occluded, that we are still providing modesty. So we're only exposing areas that we're working with. Even though the patient's asleep and they don't know any different, we still want to keep their dignity intact. We want to prevent injury. So the patient could potentially be unconscious and they're not going to be able to feel pain. So we have to make sure we are checking those areas that we know that could potentially cause some issues and put pads there or pillows or something like that. We want to secure the extremities so they don't move or fall during the procedure. Make sure all of those areas are padded and supportive, and make sure you have help when doing this. One person should not be positioning a patient. Some complications that can happen. Pressure injuries, we're familiar. If you have a long surgery, 6 to 8 hour surgery, you can develop a pressure injury from that. And it can be a regular healthy person, a walkie-talkie young person who goes in for a long surgery. Anybody can develop a pressure injury. But if you have extra risk factors like patients who already have really delicate skin or already have a pressure injury, or they're going to have that long surgery, or maybe they have diabetes or their circulation isn't the best, they're going to be at even a greater risk of having skin issues because of a surgery. So we want to really make sure that we are protecting the skin. Continuing with nursing management, just some things to keep in mind. We want to perform that timeout. That is a safety issue. Perform an equipment safety check. Make sure everything's ready to go. We're using sterile technique. You're going to be assisting the provider during intubation by making sure you have that suction equipment available, making sure the patient is properly ground. So in this picture, you can see that there is a device that grounds the patient. That's all we need to know about it. And making sure that the patient has removed all jewelry, because jewelry can be made of metals that conduct electricity, and it is a huge safety concern. So you definitely want to educate your patient about removing the jewelry, and that is the main reason why we want them to do that. Not only that, but things can get caught, and we don't want to be responsible for any expensive jewelry anyway. We want to make sure patients have the straps in place to keep them safe, and that they have on whatever is appropriate for that surgery related to DVT prophylaxis, whether it is compression stockings or the sequential compression devices. This is an example of a fire in the OR. Kind of scary. This is not a real fire. Just like fire drills in the operating room, they do simulations to make sure everybody knows what to do when there's an emergency like a fire. So they can place a special sterile drape over it. They have special solutions on hand to pour on it. But you don't need to know that. Just know fire is a risk in the OR. And continuing on with our nursing management, we want to make sure we keep the patient warm. Maintaining sterility is very important, and everyone in the OR, especially those in the sterile field, are responsible for maintaining asepsis or sterile field. Same thing, remember, sterile field, asepsis, we're using those interchangeably. Accurately record number of sponges and sharps. We want to make sure that there's none of those items are left inside a patient, so they're counted before, they're counted after. Measurements of I's and O's, keeping the OR door closed, keeping hallways clear of equipment. So again, safety issue. And what I mentioned about making sure like sponges and sharps are counted, we call that retained surgical items. So RSI, that is one of the safety checks that we want to make sure is done before and after the surgery. And lastly, nursing management. Make sure you're explaining to your patient what to expect when going into the OR. This will help to manage the patient's fear of what's about to happen. And the circulating nurse should be keeping the family updated during. Again, this will just keep them at bay and lessen anxiety. When you don't communicate this, the family or their loved one who's waiting, they can call, they start visiting, they start going, and please tell me information. So be proactive, keep your family updated. Just remember that these patients are human, and put yourself in their place and their family's place. It's a scary time, so be that nurse that you would want to be taking care of you. And that concludes this lecture.